All right, well, I think we're ready to get started. Let me welcome all of you to this workshop on implementation science and childhood obesity, sparking conversations and action to advance equity. And again, while we're waiting for everybody to come in, if you'd like to introduce yourself in the chat, we would love that. Today's workshop is brought to you by NCCOR, the National Collaborative on Childhood Obesity Research, a partnership of the Centers for Disease Control and Prevention, the National Institutes of Health, the U.S. Department of Agriculture, and the Robert Wood Johnson Foundation. My name is Karen Hilliard from the NCCOR Coordinating Center, and I'm going to be facilitating today's webinar. We are going to be hosted today by two members of NCCOR, Janet Fulton, who is a senior advisor for science in the Division of Nutrition, Physical Activity, and Obesity from the CDC, and April O, who is a senior advisor for implementation science and health equity at the National Cancer Institute in the National Institutes of Health. We've got a fantastic program for you today, and we're going to begin first with some opening remarks from Janet and April, and then we're going to move into our keynote address from Taryn Swindle at the University of Arkansas for Medical Sciences. And then after Dr. Swindle presents, we'll take a short break and then come back to our workshop sessions for today. The first session is on assessing context and adapting interventions to meet the needs of the community. And our speakers for that segment are Gabriela McLaughlin from Temple University and Sandra Echeverria from the University of North Carolina at Greensboro. And after each of our guests, there will be an opportunity for you in the audience to ask questions of them individually. And then all three of our first guests will come back to take part in a panel discussion that will be moderated by April O. Then after another break, we're going to come back to our second session, testing of implementation strategies and planning equitable implementation and sustainability. And our guests for that session are Valerie Bluebird Jernigan from Oklahoma State University, Courtney Parks from the Gretchen Swanson Center for Nutrition, and Deanna Hulsher from the University of Texas School of Public Health. And again, you'll have a chance for Q&A individually with each of our speakers today. And then after that second session, we'll have another panel discussion, that one moderated by Janet Fulton, and then a few closing remarks. And again, I'd like to call your attention to the fact that we have two breaks built into today's program where you'll have an opportunity to get up and stretch. We hope that you'll be able to hang with us for the entirety of the sessions before and after those breaks, and then you'll have an opportunity to get up and move around during those times. A couple of quick housekeeping notes for you today. If you have a question for our speakers during the webinar, as I said, there will be a Q&A individually with each of them, but please go ahead as you think of that question and put it in the Q&A box. Don't put it in the chat, put it in the Q&A feature that you see at the bottom of the screen. And if you need technical assistance, though, at any point during the session, you can let us know using the chat box. If you have any trouble logging into the webinar, or if any of your colleagues do, you can email us at ncor@fhi360.org, and we'll work with you to resolve the problem. And with that, again, a reminder to put your questions in the Q&A as we go along today, and then we'll come to them in each Q&A section. And I'm going to now pass it on to Janet Fulton from CDC and April O from NCI, who both led the planning of this workshop. And Janet's going to give a brief overview of what the purpose and goals are for today, and April will then set the stage with some key definitions on implementation science terminology.
Fabulous. Thanks, Karen. I really appreciate it. Good morning, everyone. Before we begin and we launch the workshop, I really want to I think on behalf of, April and I and everyone, we really want to just sincerely thank all of our presenters who lent us their time and their expertise, and I'm sure you're going to enjoy every one of their fantastic talks. There was also a committee through NCCOR that really helped with the planning of this webinar. I really just want to call and shout out to them and just say a sincere thank you. Our expert advisor, Taryn Swindle, that you're going to be hearing from in a moment. Thank you, Taryn, for your wisdom and your expertise. Karen, thank you for moderating this. I really appreciate everything you've done and all the planning meetings we've had to put this all together. To Vaughn, who's really been our manager and savior in putting the workshop together. And to my co-conspirator here in all of this, April, thank you so much for everything you've done to get where we are today. So with that, you may be asking yourself, why are you here? Implementation science is relatively new to many of us, me included. And recognizing that, we really had this unique opportunity with NCCOR, who are experts in childhood obesity, to begin to build the capacity for implementation science. And that's one of our primary purposes in conducting this workshop today. We also thought it was an important goal for the workshop to really be engaging and present to you not only the information, but really kind of paint the picture through examples of implementation science in action. And not just any action, but those equitable actions that we can use to illustrate principles of health equity as applied in underserved populations. But I think you're in for a real treat today, and really looking forward to the presenters and the discussions that follow. I think that'll be just kind of like icing on the cake, or maybe on the fruits and vegetables. So next slide, please. We've developed a great list of resources for you all about implementation science, from pre-implementation to sustainability of implementation. And this is for you to have once you leave the workshop. So there's lots of resources out there. We thought these were sort of some of the big ones that you would want to have, and we'll put that link in the chat. And so that's it for me. I will now pass the baton over to April.
Great. Thanks so much, Janet. And good morning, everyone, from wherever you may be dialing in from. Thank you for joining us. So as Janet mentioned, that throughout the presentations today and our time together, our great set of speakers will be providing some key examples of ways to apply implementation science, and also with a health equity lens. So I thought that before we go into these sessions, it may be helpful to have some common key terms as we listen and as we reflect on these different case examples. So first, as many of you are familiar, how we're defining health disparities and health equity. Health disparities are really those differences that are closely linked with social or economic disadvantage, and they adversely affect groups of people who may have systematically experienced greater social or economic obstacles to health based on a variety of characteristics as listed here. Health equity, on the other hand, is attainment of highest health for all people. And as we apply a health equity lens, it requires valuing everyone equitably. And there is an acknowledgement and intentional focus on the ongoing societal efforts and impacts that we can take to address avoidable inequalities, address and acknowledge historical and contemporary injustices, and ultimately will have impacts on elimination of health disparities. Next slide. This illustration is one that you may have seen before, but I think it's worth putting this forward in terms of clarifying some of the words that you'll be hearing as we move forward. There is a unique difference between an inequality, as seen in the upper left corner, where is unequal access to opportunities. Equality, on the upper right corner of the slide, this is where there may be evenly distributed tools or assistance. You can think about that in the case of interventions. However, you can see on the right side, while on the left side, the girl is able to pick the apple with the same tool or resource being a ladder, the boy on the right side is still unable to access those apples in the tree. On the lower left-hand corner, you can see here injustice. This is where there's fixing of the system to offer equal access to both tools and opportunities. And here you can see that there's some adjustments made to the tree, leaning the tree that was previously leaning more towards the left, towards the girl. Now we have changed the structure of the tree so that we are having the tree lean more towards the middle, so that those tools and assistances that were offered before with the ladder are now able to be accessed equitably for the two children. And in the bottom right corner, this is where I think many of us would like to reach, is customizing the tools that identify and address those inequalities. And here, this is where implementation science can come in thinking about different strategies. What are the strategies that we can apply so that with the equity lens, so we're taking into account that structure, we're taking into account how those tools and assistances are distributed in order to achieve equity for all. Next slide. So what is implementation science? Implementation science intends to bridge that gap between research, practice, and policy by building a knowledge base about how health information, effective interventions, and new clinical practices or guidelines and policies are communicated and integrated for public health and healthcare service use. Dissemination research is a scientific study of targeted distribution of information and intervention materials to a specific public health or clinical practice audience. And the intention there is really to understand how best to communicate and integrate the knowledge and the associated evidence-based interventions. Implementation research is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve individual outcomes and population health. With that, though, these tools and resources or these definitions are available in your resource link that's listed in the chat. And we encourage everyone to take a look at those materials either during or after the workshop. As you are synthesizing what you're hearing today. I will also throughout the session be popping into the chat different resources related to the discussion from each panel. And hopefully that will continue to be a resource to you as you think about integration of implementation science with a health equity lens. Thanks so much. And I will toss it over now to Karen.
Thank you. So we have a poll for all of you in the audience. We'd like to get a sense of what your current level is in terms of your experience with implementation science. So if you can respond to the poll, are you a novice who is ferociously taking notes today? Do you have sort of an intermediate knowledge where you could hold a conversation? Or are you an expert who could explain implementation science in your sleep? We'll give just a moment for folks to reply here. This is great. We'll be showing you in just a moment, sharing with you who is in the audience today. We have a few more folks to respond. I'm just going to give you a moment or two. Don't think too hard about it. Just where would you place yourself, novice, intermediate, or expert? And we'll give just another moment here for folks to respond. 3, 2, 1. I think those are all the responses we're going to get. Let's go ahead and share the results. And as you can see, there's we have only a few experts in the audience today. Most of you are pretty evenly split between novice and intermediate, and that's very helpful to our speakers because we'll try to gauge the presentations to be helpful to both those who are brand new to this topic and those who have a little bit of experience and are here to learn more. So thank you so much for participating in that poll. I want to introduce you now to our keynote speaker for today, Dr. Taryn Swindle. And Dr. Swindle is an associate professor in the Department of Family and Preventive Medicine within the College of Medicine at the University of Arkansas for Medical Sciences. And very broadly, her research program focuses on understanding and improving health and developmental outcomes for children impacted by poverty. Dr. Swindle has a particular focus on obesity prevention and nutrition promotion for young children in families impacted by poverty. And so I'd like to turn it over now to Dr. Swindle.
Thank you so much, Karen. It's an absolute treat to be with you all today. I cannot emphasize that enough. I'm going to jump in with a story about myself. I want you to imagine me as a young, eager research assistant. I'm trying to do the best job possible so that I can get a faculty position at the end of my PhD program. I'm working on a USDA-funded obesity prevention project in early care and education settings. I've helped develop a program. I've helped develop its training. I co-led the training. I'm so invested and so excited to see this program come to life. And I got the good fortune to be able to go watch it in the classroom. So I go out, I watch this first lesson, and I thought I was going to have to abandon intervention work altogether after that first visit. The teachers were not applying the training. The evidence-based practices were either missing or all wrong. I mean, it was a nutrition promotion lesson, and the teacher told the child that she hated vegetables. Out loud. To his face, she said this. So I go back to my office. I'm completely defeated. I think, oh my goodness, what am I going to do? We've created a program that nobody can use or will use correctly. And I was really learning at that time that creating evidence is not enough. So through some really interesting turns, I got to the solution that is implementation science. And it changed the trajectory of my career. I'm so glad, and I'm so glad to be here to talk with you about that today. And of course, over time, how that's developed to intersect with equity in my work as well. So next slide. I'm going to go ahead and start off by giving some funding information and disclosure information. Next slide. Before jumping into the problem. And that problem is we have huge inequities in implementation when it comes to science and the waste that we see. And so we know it takes too long to get too little of our work into practice, but it also reaches those that need it the most, the least. And so that's a real issue. And in fact, some of the evidence that we create worsens inequities. The review that I've listed there identify that some mass media campaigns, some broad policy efforts worsen what we know to be existing health inequities. These are problems. Next slide. And so implementation science was developed to try to close the gap between not using the research we're generating, but increasingly it's seen as a way to enclose those equity gaps as well. And so this is a common definition you all may have seen, but I want to focus on a couple key pieces. First, it's all about getting what we know to be good evidence-based practice into routine. That's what it's about. And it's about studying the ways that we can do that, the scientific study of those things. And so a lot of times in the nutrition space, I interact with folks that say, isn't it just good process evaluation? And I'm like, no, please. And so I've written about that before. There's a link there, you can check it out. But it's not just good process evaluation, because in implementation science, we're doing systematic, research-based manipulations to see what are the best ways to get research to practice. So there's a couple more animations that'll play out there, but we'll go ahead and go to the next slide. And so implementation science, we are looking to generate, or to implement rather, a lot of innovations. And so these are the 7 Ps we often use to describe what those are. So products, policies, pills, programs, procedures, principles, practices. You can probably find yourself in that list. You've probably created or tried to implement one of those in your own work. And so that's what implementation science seeks to do, is get these things into practice. There's also some key terms that we're going to look at on the next slide. And so the first is that term innovation. This is the thing that you're trying to get people or systems to do. And how you're doing that are implementation strategies. These are the actions that you're taking to get people and systems to do the thing. And then finally, all of this is taking place within a context. And so we want to always be thoughtful about the inner and outer environmental factors that might be influencing a particular implementation effort. Next slide. So one of my primary mentors is Jeff Curran, and he has a great tool for thinking about implementation science and for making it simple. And I encourage you to check that out. But at its core, he summarizes implementation science this way. What are you going to do to get people to use your thing? That's what it's all about. And we ask questions around that key concept. I am not as eloquent as Jeff, and so I make things more visual or more confusing. I don't know, you tell me. But I have a picture here for us to help us think about more about what implementation science is. So let's pretend we've got to get across this chasm between these two cliffs, and we need an innovative solution to do so. And so that's what we have here. We have this innovation that is the unicycle and the tightrope. But we also need help as we go. So we are going to use an umbrella to support us, to help us with our balance. And so that's the implementation strategy. And this is all taking place in a context. Presumably, we're thinking about this a little bit differently if it's windy, or if we're way high, if this chasm is very high, or if there's something dangerous below. And so this may seem a little silly, but there's a few things I want to note about this. First, the thing and the strategy are distinct. The unicycle is not the same thing as the umbrella. What we're asking people to do and the supports that we're providing them to do it are not the same. And this often gets confused for people that are new to implementation science. So you want to be able to pull those apart and disentangle those. And then the things that we choose, the strategies that we choose, should reflect the context. We might make different choices depending on the contextual variables at play. Again, those things like the weather, the height, those kinds of things. So I want to summarize in a nutshell on the next slide what implementation science is. And this is oversimplified, but some things that you definitely will want to do as you move through an implementation science process. First, you've got to know what the gap is in the use of the innovation. And you got to know why it exists, and from an equity lens, most importantly, for whom does the gap exist? The second thing is you're going to want to select strategies to address that gap. And you want to do this with partners at the table. That is equity. The third thing is you want to determine if your strategies have impact. We've been doing that very well in implementation science, but we also want to do it with an eye to equity. Are we having equitable impact? So now I'm going to move to the second part of my talk where I unpack across phases of implementation some examples of what we've been doing. And I love this concept of conversations. I hope that's what it feels like, and I hope to continue them with you today. So the EPIS framework is a very common one in implementation science. I see April's dropping in the chat, so she could probably give you that link to their website. If not, I can after I'm done. But it's a great resource to think about phases of implementation and the things we might want to consider at each phase. So let's jump in and let's talk about explore and prepare. And that's my next slide. Yeah, so this is my favorite phase of implementation. I love doing work in this space because we get to think about what is the right thing to implement? How are we going to meet the needs of the people? We get to think about what are the barriers and facilitators to meeting those needs, to doing the thing that would meet those needs. And then when it comes to equity, we get to wonder about why do inequities exist and which ones are they? Are they around the access to the evidence or the determinants of the use of the evidence? And what are the highest order ones? The higher in the system that we can find determinants, the more likely we are to have downstream impacts. Then we think about things like, do we need to adapt this thing for this place, for this group? And whose evidence was it anyway to start with? Who was involved in the original trials that generated this evidence? And is this evidence appropriate for this group of people? And then finally, what help would be needed to do this thing? So what is happening in this system that must change or be addressed to do the things to meet the needs of the folks? So I want to talk a little bit now about some exploration work that we've done in around feeding practices in the early care and education space. So we did interviews with over 70 educators across a number of different subgroups and samples. I've listed the studies there because we wanted to help us understand what's making it hard to use evidence-based feeding practices in their setting, and what's making it tempting to use feeding practices that are just not appropriate. We also surveyed over 300 teachers. We really wanted to get to the bottom of, why are they hurrying children to eat more and more? Why are they 20 times more likely to pressure children to eat than to cue them to hunger and satiety? Why do they use shame and comparison at meals so much? And the answer at the end of the day is hunger in brief. About 2 in 5 of the early care and education professionals that we've talked to have experienced food insecurity, either in their childhood or at present. And that is a very high number. 34 to 38% of teachers in ECE settings are currently food insecure. So they're worrying. They're worrying about the children in their care experiencing the same thing, and that impacts how they show up, their readiness and their ability to use evidence-based feeding practices. And this quote always just sits with me. As a teacher said, it brings up that inner struggle. Do I fill their belly, or do I expose them to new foods? And so that's a tension that she's holding as she's being asked to do new evidence-based things. So I want to look now at the full example of this work on the next slide, where the thing was feeding practices. That's what we were trying to change. The context was early care and education. You can see the strategies that we selected through a co-developed process with the partners. But I also want to just highlight, with this food insecurity piece in mind, we specifically included a strategy to address the social determinant of health. We developed maps of community resources where teachers or the families they serve, we didn't ask or judge or track, we just distributed places where they could get access to food resources on a regular basis in their community. This package of strategies was able to lead to decreased use of inappropriate feeding practices and improved use of evidence-based ones, but it was still harder to see shifts among teachers who had been personally impacted by food insecurity. So let's think about the implementation phase next. So in this phase of implementation, we get to ask more exciting questions. We get to ask things like, do our strategies work with getting people to start doing the thing? So adoption. Do they work to help them do it well? Fidelity. Do the strategies work to help the implementers' perspectives of the thing? Acceptability, feasibility, appropriateness. Do the strategies help or hurt? Cost effectiveness. And that can be at multiple levels: the cost effectiveness of the thing, the cost effectiveness of our strategies. Do our strategies help the thing become routine? So we're thinking about penetration there. And then, are we creating equitable change in both our implementation and our effectiveness outcomes? So we want to have an eye to individual level variation across social determinants of health and how people are responding to what we're doing. Also, there's a reference I'll share in the chat about progress considerations. So this is place of residence, race, ethnicity, culture and language, occupation, gender, religion, education, socioeconomic status, and social capital. And so if our work is equitable, we will see the same kinds of effect sizes across levels of those characteristics. And that's a really important question we can ask more often. All right, so I want to talk now about some work that we did during my K Award, where that intervention I was telling you about, we wanted to help teachers do it better. And so we were looking at how can we support them to role model, to use positive feeding practices, to provide hands-on exposures to fruits and vegetables where they don't say things like they hate vegetables, where they're using a promotional mascot. So we asked some of the same questions in our exploration phase about what was making it hard, what was making it easy, and we landed on this comprehensive set of implementation strategies. I like to visualize mine, so that's what I've done here. But at the foundation, actually, I also want to give a shout out to a colleague of mine, Jana Martin, who is on the call today. She created this beautiful graphic, so thank you, Jana. So at the foundation of what our strategy is external facilitation. Everybody gets a coach to help them move through the process and of implementation. And then the context gets support. We train a local champion in how to navigate and advocate for the program at the local site. We sit down with the leadership and have a formal commitment process and a blueprint of implementation so we can talk through what to expect and how they can move through the process at their site. And then the attic of the house is the support given to the frontline implementer. They all get a reminder of a cutting board with the evidence-based practices, but then tailored support. They can have handouts and videos when they're lagging in their use of the EVPs, or they can have support, a thank you, incentives when they're doing well. So this was worked out okay. It worked out we got some promising results at the end of this small scale trial. We have promising data on fidelity, implementer perceptions, organizational readiness, and we also had cost data. It was costing us about $261 per classroom to deliver this strategy, which in the implementation science field is cheap. But this is not cheap for ECE. When we think about the resource constraints of the setting, we knew that we couldn't scale it or pass it to a community partner at that cost. So we started to think about an adaptive approach to implementation. Can we save the attic for only the places that need it? So we gathered input from EC partners on how to do that and who needed what. And we're currently testing that in an R37 study. So that's summarized on the next slide, where I show that the thing is WISE and it's for EBPs. The context continues to be early care and education. And you can see how our partners helped us tease apart what was low intensity implementation and what was high intensity implementation. So through an adaptive trial design, we're randomizing people to get different levels so we can start to think about, for whom does low intensity work? How can we increase the high only for when that's needed? Are we triggering the right mechanisms for folks as we do this work? All right, and so now we talk about our last phase of implementation, which is sustainment. So we get to ask really great questions here too. How do we keep places doing the thing and doing it well? What needs to change for things to continue about the context or the thing itself? What parts of the thing need to be adapted for a sustained impact to happen? And how do we sustain equitably? That's a really important piece, because if we think about sustainment, the grant goes away, right? And so those that are most able to sustain it, are they going to be the ones with the most resources? That's not what we want. That's not equitable sustainment. So in our work on the next slide, we're thinking about this hopefully in a way that challenges the paradigm. We're trying to get away from just, thinking about one place, one thing, because maybe that's a critique you've had as I've talked today, that could happen in many of our work. But we're trying to think bigger and collaborate across things, across innovations, to understand, are there different factors that impact sustainment based on different program types? Or are there things about the places or the people that transcend characteristics of the thing when it comes to understanding sustainment? So a little sneak peek on this: COVID undermined a lot of our efforts in the early care and education environment. And what we're seeing so far is the people that are sustaining are those that are in small communities with stable staff and really clear systems. And so those are factors that would implement, or rather affect, equitable sustainment. And so the slide here on this work is just to illustrate that the things are two. And so I would say that that's an opportunity we have. Let's study multiple things as we're doing this work. The context continues to be early care and education. And we're going to design strategies for sustainment that we can test in a future study. And we're going to be able to do that by looking at those that have been low, medium, and high sustainers of these two programs. We're going to know which theoretical constructs mattered the most and really be able to translate those lessons learned forward. So I have a few key takeaways as I wrap up my time with you today. When I think about the exploration and preparation phase, I think we have an opportunity to think more about the social determinants of health and to think about how our implementation strategies may need to explicitly target these to advance equitable implementation. I would also argue that we need to find and value local knowledge as we do exploration and preparation. And as we know in implementation science, we've just got to embrace the idea that context is king, and we cannot move away from that. When it comes to the implementation phase, we need to acknowledge also that not everyone needs the same thing to achieve quality. And so the graphic there that's been shared already, a different version, but give people what they need. And that moves us away from standardized packages of strategies. That might make some of us uncomfortable. I get it. But maybe that's what we need to do. We need to infuse equity into our strategies and our designs. And that means that pragmatism wins. So we got to think about more of these adaptive designs that can help us develop equitable strategies that could be passed to our community partners. And then finally, with sustainment, we have to begin with the end in mind. If we're not thinking ahead about what's going to be required to do these things and these strategies after grant funding is gone, we're going to face inequity in sustainment. Finally, I hope that it's come across in my talk today that it's a passion of mine to include partners and end users in engagement and engage them at all phases. I believe this is absolutely essential to doing equitable implementation. So I'll end today with a couple of questions for you and an invitation for questions for me. You know, which phases of implementation are you working in the most? Where do you see places and opportunities for you to add equity questions? And then, of course, what questions do you have for me? Thank you again for the opportunity to be here. It's just been such a treat.
Thank you so much, Dr. Swindle. And we are about to take a break, although we would love to ask for your questions. If you have any questions, you can put them in the Q&A box and we will try to address them after we come back from the break, but we're right at our break time now. We're going to take a brief 10-minute break, and I hope that you will take some time to stretch your legs and grab some water. While you're away, though, we have something we'd like you to think about. How do you choose what's right for your community when you're implementing an intervention? So think about that question as you take your break. And when you return, let us know your response in the chat. And while you're gone, although we hope you'll step away from the computer if you're not able to do that, if you'd like to just get out of your chair and move a little bit at your desk, we're going to play a fun video, which you can enjoy or not. You can turn your sound down if you don't want to hear it. We invite you to join us for a physical activity break if you would like. And we will resume in about 9 minutes. So please come back then and think about the answer to that question that you can put in the chat. What's right for your community? How do you choose when you're implementing an intervention? All right, enjoy your break. All right, welcome back from the break. As folks are coming back to join us, we would love to see your responses in the chat to the question that we asked at the top of the break, which is, how do you choose what is right for your community when you're choosing how to implement an intervention? So any thoughts on that? Anybody that would like to jump in with comments, you can go ahead and put those in the chat. And we will try to not only will we be able to share those with each other, but we'll try to address some of those thoughts as we get to our panel discussion in a moment. All right, so I'm seeing a few good responses here. Asking key stakeholders what is needed, asking the community through conversations and surveys, fantastic. Asking if it honors their identity and dignity while creating a healthier community, excellent. And any other thoughts or any other processes that you use? Seeing a lot of folks having conversations with, actually asking the community, asking stakeholders. Somebody's mentioning on-site visits. Excellent. So these are some of the issues that we're going to be covering as we get into our first workshop session here. Let me go ahead and introduce our next group of speakers, and where each of them will present, and then they will be rejoined by Dr. Swindle for a panel discussion at the end. You will also have a chance to ask each speaker some individual questions. So please put your questions in the Q&A, and we'll either come back to it in those individual Q&A sessions or in the panel discussions if possible. All right, so let me introduce you to our next speakers. The title of their session is Assessing Context and Adapting Interventions to Meet the Needs of the Community. And our two speakers today are Gabriella McLaughlin and Sandra Echevarria. And Gabriella McLaughlin is an assistant professor in the Department of Kinesiology in the College of Public Health at Temple University. Her current applications of implementation science reflect a variety of topics pertaining to health disparities in cancer prevention, addressing food insecurity in underserved communities, school health policy implementation, and community approaches to obesity prevention more broadly. Dr. McLaughlin is deeply committed to improving implementation of evidence-based policies and programs that address health equity through pragmatic approaches. And let me introduce you also to Dr. Echevarria. She is an associate professor in public health education at the University of North Carolina, Greensboro. And from the start of her career, Dr. Echevarria has worked with community partners in the implementation of programs that can mitigate social inequities in health. One of her current projects seeks to identify evidence-based models that can address social barriers to physical activity adoption for Latinx people living with diabetes by integrating clinical and community data systems and resources. So we will start first with Dr. McLaughlin, and again, a reminder to put your questions in the Q&A box so that our speakers can answer them at the conclusion of each presentation. Dr. McLaughlin, it's all yours.
Thank you so much, Karen. It's great to be here, and thank you all so much for taking your time to join this brilliant workshop. I'm just so honored to be among such amazing minds. So as mentioned, I'm an assistant professor at Temple University College of Public Health, and I'm also an affiliate faculty at the Washington University Implementation Science Center. Currently actually in St. Louis at their IS2 Institute. So I'll make a massive plug for that as a really great training tool, and I'll put the link into this institute for anyone who's interested in being a faculty fellow. It's a really great initiative. So if you want to go on the next slide, I'm going to dive right in because a lot of the problems that we're sort of seeing, as Dr. Swindle mentioned in the keynote, are arising from not only poor implementation, but inequitable implementation. And so that really tees up a lot of the stuff that we're going to talk about in this session. And one of the biggest things that struck me as I was going through my postdoc and now as a faculty member is just how much we don't involve are key implementers as decision makers from the start. I'm also a licensed teacher, so I've been teaching in the public schools in the Midwest and then now working with School District Philadelphia. I'm noticing that so many decisions about what to implement, how to implement are happening on the ground, but we as researchers aren't always privy to what's happening because we don't take the time to learn from these amazing experts from the beginning. So a colleague, Dr. Martinez, and I published this article in our actual college journal, which really tries to address some of the ways that we can use implementation science to address health disparities. And we really focus on this idea of an ongoing bidirectional dissemination. So in this figure on the left, I think the next slide sort of expands that, thank you. We can see that we have these evidence-based interventions on the left-hand side. So using Dr. Curran's heuristic and then also Dr. Swindle's heuristic, that is the thing. So a couple of examples from my field are food assistance programs, and then for Dr. Martinez's research is HIV care. We need to really understand how not only we can improve implementation, but how we can measure it and how we can have appropriate measures to really understand not only the outcomes of implementation, but the impacts on equity and potential inequity that we might be causing as researchers. Through doing this and co-creation of the desired outcomes to implementation with our partners, we can hopefully get to a point where we're having this really great collaboration to enhance sustainability, but really importantly, to just enhance that decision-making and make sure it is shared and equitable across the board. Oftentimes I've gone into schools and they've pretty much just asked me, what do you want? What can we help you with? But I think we need to really flip that conversation and think about how can we help you with how to serve these individuals and these systems at play. And they know the most about their systems. So it's our job to listen first before we start to act and place more burden, more interventions on these systems without really thinking through what their contexts are like. So on the next slide, I'll just kind of run through a little bit that hopefully can give you some context. And again, Dr. Swindle has given a really great foundation as to some of the focus of my work in recent years. But just to highlight the complex, nuanced, and very pervasive relationship between food insecurity and risk for chronic disease, such as weight and obesity, like what we're talking about at the NCCOR seminar today. So we know it's not new information, but on the right-hand side, you'll kind of see some of the pathways that have been exacerbated and worsened by the COVID-19 pandemic, which is still ongoing. We are seeing that even more than before, people who were living in conditions with food insecurity are being pushed even further into that disadvantaged position, and we are minoritizing them by not serving them in appropriate ways. This then causes increased risk for childhood weight and obesity, especially in minoritized populations such as Black and Brown communities, low-income settings, and so forth. And so it gives us this really big impetus to not only focus on how we can intervene in these systems, but how we can partner with the people already doing the work, which is a really important thing. Really doing the work that honestly, many of us researchers cannot imagine doing ourselves. And so again, just trying to really emphasize that we don't always have to start with something new. Sometimes we can help make something that exists better. And so the next slide, I'm going to talk to you about what that actually is, what I'm trying to do, and how I feel like we can sort of bolster some of these ongoing policies and practices. One of the things that I really had to grapple with, and this really was brought about by the onset of the COVID-19 pandemic, was how we can better implement ongoing policy, systems, and environmental interventions that already address health equity and health disparities, but there are clear implementation gaps or chasms. So as you can see, one of the CDC images on the right-hand side, which is really helpful to me in terms of looking at not only programs, but measurement and policy kind of aligning to really address these issues. I think if you advance, there's a couple more pieces on this slide. Sorry about that. One of the major programs that exists right now to combat food insecurity and improve children's health behavior is community eligible provision, which basically provides free school meals to any school or district that has 40% or more of its students eligible for free and reduced meals. So for example, I work in Philadelphia and I partner with them as a very close partner. All of their students in all of the 270 schools they have, which is around 180,000 students, all of the students in Philadelphia can receive free or reduced price meals because more than 40% of its students are eligible for free meals. And that allows many schools and districts to not only save time and money by not having to collect income information from families at the end of the school year, but also allows them to make these programmatic decisions about what they serve and how they can sort of streamline operations of food service to sort of address these pragmatic challenges that we have when we're trying to address food insecurity. But we also have nuanced problems of stigma, discrimination, lack of access, cultural dissonance, and other issues that we know through the literature as well. So one of the problems that we're facing with a policy like CEP, which is basically universal school meals in another dialect, is that we have several implementation gaps. One of those is participation on the student level in school meals. Many students do not know still that they are able to receive these free school meals. And we know through amazing research that's been done by colleagues of mine and other colleagues across the country that taking part in these programs is a massive mitigating factor for risk of overweight and obesity in childhood. So we know that this is a thing, right? This is a policy, this is an evidence-based policy or intervention, but how do we implement it better? And so instead of sort of thinking about how we can go in with a new idea or a new intervention, thinking about how we can actually build capacity in the systems. So on the next slide, I'll just kind of show you some of the issues that I'm trying to work and grapple with. We know that more attention is needed on implementation processes and outcomes beyond compliance. And so these are the findings of a review that we completed in 2021. And we see that when we actually try to measure these policies, we're only really measuring fidelity and compliance. We've got a few other bits and pieces that relate to some of our implementation frameworks, but again, we're still really heavily reliant on that fidelity compliance piece and not so much on equity of policy implementation. Next slide. And so we just had our article published this morning, which I think is going to be the link to put in the chat for you guys to see. But basically, we are undertaking a equity-focused measure development project. And this is going to be ongoing for the next sort of 6 months to a year. We've already sort of started the main groundwork and sort of A1 is mostly complete. But our focus is really on identifying key constructs from health equity and implementation science frameworks and really making sure that the implementation experts, such as teachers, food service representatives, administration, anyone working in school systems, have a seat at the table from the beginning and actually are able to choose what constructs we put into our measures. And so that was just completed through AIM-1 through a survey. And now we're kind of moving on to some of the pilot testing pieces to do some cognitive testing on interview guides, surveys, to really examine not only the determinants and processes, but the outcomes of implementing school meals better and how can we address that so that when we do have these interventions and implementation mapping tools, how can we actually measure its impact? Next slide. And so just on this last piece, I wanted to show you some of the ways in which we can actually work with school districts and other stakeholders, such as the Urban School Food Alliance, that actually is funding my pilot. And here's just one example of something that we can do, and it's called implementation mapping. And so basically, many of us are already doing this in terms of plan, do, study, act sort of mentality, heuristic, but it really kind of helps us to outline some of the ways in which we can pragmatically work with our partners to come together and arrive at an implementation intervention together. This is a really important piece because not only does it increase buy-in, but it also increases that capacity to actually do whatever it is we're asking our stakeholders to do, because they're going to be the ones that really come with the ideas and match those ideas to the challenges and nuanced issues they have in their context. So last slide, I wanted just to sort of provide some future directions. And I know we only have a few minutes, and so I wanted to kind of give us a little bit of ideas as to what I think we would definitely be best suited for in terms of addressing implementation science and child obesity with an equity focus. Is not only do we need better understanding of those contexts and those factors that are determining implementation, we also need to have those tailored interventions. And so again, those adaptable, malleable interventions, such as the ones that Swindle was mentioning in her talk. We need to have massive considerations of context. So implementation mapping is just one way, but it's a great way we can do that. And then again, we also need to have sustainable solutions and pragmatic tools and metrics. And so hopefully the work that I just kind of introduced is going to help us kind of get a little bit closer to that as well. So I'll end my talk there just because of time, but happy to take any questions, and thank you all for listening.
Thank you so much, Dr. McLaughlin. And we do have one question for you. In an earlier slide, you mentioned COVID-19. What have we learned from the pandemic about equity-focused implementation science?
I mean, what haven't we learned, right? One of the things that I think has really pushed people to think about is to slow down. COVID really forced a lot of us to slow down and just take a second to think about what is it that we're giving back to the communities that we're working with. Because for a while, and Taryn mentioned this in her talk, we didn't really have any implementation going up. Things just had to stop. And so it really kind of, at least for me, forced me to sort of reevaluate, is what we're doing and pushing on these school systems, is it really going to make a difference? And so I think that was one big thing that I took away. And I think all of us can take away, is to sort of think about every metric, every data collection tool, and every aim that you have. Is it necessary? And how can we work a bit more intentionally and a bit more carefully to make sure that our partners have a seat at the table, or we have a seat at their table, right? Because they're the ones doing the work. So I think that's a really important piece, is to shift that mindset from this is our research to this is how we're helping ongoing systems and interventions be evaluated and bolster implementation. I think that was a big takeaway for me, at least from the pandemic. There's many more, but I'll keep it brief.
All right, excellent. Thank you so much. And we encourage everyone in the audience to put your questions in the Q&A box. We will get to them either after each individual speaker gives their presentation or during the panel discussion. So thank you so much for that. And let me now turn it to Dr. Echevarria.
Great. I think we've just transitioned to the afternoon. So good afternoon, everyone. It's a real honor to be here today and present with my fellow colleagues, and also want to just acknowledge and thank our leaders, Dr. Janet Fulton and Dr. April O, for a lot of their work, and others who've been involved in planning this session. I also want to begin by just acknowledging a little bit more who I am. I am a first-generation college graduate in my family. And so for me, the question of health equity is both professional and personal. And so I navigate both of those spaces in the work that I do, because not only am I the first person in my family to graduate from college, I also lived in a lot of the communities that I'm now conducting research with. So I wanted to acknowledge that my lens and comes from both my professional interest to address inequities, but also my own lived experience. Next slide, please. And what I'm going to share with you today is a concrete project that I've been engaged in that really starts off with this idea of pre-implementation science. And yes, and we just had a wonderful talk about giving us kind of those definitions and approaches, and I'm going to share a little bit more about that. So I'm going to describe, as you've heard, right, context is really important about the work that we're doing. And so really centering this project around the context that I am working under, what my long-term goal and study objectives are, and then also trying to share. There are lots of different frameworks and strategies you can use in implementation science. I think I want to echo what others may have been writing about and may have said or will say, is that it's probably not necessary for you to invent frameworks. Use what we have. I think there's some that are really useful, but certainly adapt them to your local reality. And I'm going to share that where I am with a lot of this work. Next, please. So in terms of context, I am actually also newly arrived here in North Carolina, just living here a couple of years. And part of my reason for moving here too is because I saw this interest and opportunity to really work with Latino communities. And just also want to disclose that I use the term Latino. I recently co-authored a paper on the use of Latinx or not, and when it may or may not apply. So I encourage you to look further into that topic. And so for me, Latino is because the work that I'm doing addresses Latino and Latina individuals. That's part of what we covered in this other paper. So I use the term, but obviously also not in any way to exclude others who identify differently. So for Latino populations, here in North Carolina, there's been a huge growth of the Latino population in the South. If you could just click one more so that I can highlight that on the, yeah, great. So we have a huge burden of diabetes here in North Carolina. As you can see, the average diabetes prevalence has been increasing over the past few years, and it's much higher than the national average. And then in North Carolina specifically, we've seen a huge growth of the Latino population here. And so currently we have the largest share of Latinos living in a lot of these southern states. Not necessarily the largest percentage change, but largest in terms of numbers. Next. And so one of my areas of research is to promote physical activity and to really address physical activity inequities. And what we know about physical activity through randomized clinical trials is that it improves overall survival, reduces the incidence of select cancers, right, like breast cancer, colorectal cancers. And we also know that other risk factors such as type 2 diabetes and obesity may also contribute to higher cancer burden in populations. But we have two big challenges. And when I started this work, one of the things I saw is this is really kind of division between community-based physical activity programs and or either clinical-based programs, right? So think of, for example, the RX for exercise, where people are literally testing the prescription of physical activity in clinic settings. And I think both of those areas of work are really important and necessary, but there hasn't been a lot of integration. So in other words, how do we begin to integrate the work that's happening in community-based settings with community organizations, with community leaders, and clinical care systems, right? So that we really have a deeper connection. And then in terms of Latino families and Latino youth, we know that they also face multiple social and environmental disadvantages, right, to adoption of physical activity. So my project is really situated in trying to identify these social barriers that they may face. Next slide. So there's a nice paper that, and someone mentioned it earlier, right, that sometimes it's helpful to think of what your long-term goal is, right? What is that long-term? And then start off early on to get to that long-term goal. So my long-term goal is to essentially test the implementation strategies that would be effective to integrate innovations such as real-time referral systems that we have adopted. I'll talk a little bit more about that in a minute here in North Carolina in hospital systems that can support, again, that integration of clinical and community-based systems to promote physical activity. But specifically, I received funding through NIDDK, and I'll share that at the end of my talk, my funding resources, to conduct this pilot study that characterizes the multiple social and environmental contexts that may support or serve as barriers to physical activity. And again, testing that acceptability and feasibility of integrating these systems to promote physical activity in Latino populations. Next. And again, I mentioned there are lots of different frameworks, but one of these, and we saw this in our great talk by our keynote speaker, is that there are different ways for us to think about implementation, and some of them are just drawn on research processes, right? And I think this framework kind of highlights kind of all of the different ways and processes involved in implementation strategies. And I'm just going to focus on four, the ones that are highlighted in the darker blue: planning, educating, managing, quality, and policy context. Next slide, please. And here they are. So I want to begin by saying that my talk and what I'm sharing with you is, again, really situated at this very early phase of pre-implementation. And so what does that mean, right? So we already heard about the implementation, right, definitions, right? So we're trying to change something, right? So my thing here is physical activity. And I'm trying to see if what I will do, right, the integration of referral systems from the clinic to the community, from the community back to the clinic will work, right? And what I need to do to enhance that, right, work so that it works really effectively for promoting physical activity. And I'm doing that by connecting with community-based organizations, establishing a leadership team within the clinic system so that we can better define how we will create this integration. And I thought this other paper that's been that was recently published a couple of years back really was helpful also in terms of terminology and thinking about how you can create and establish an implementation study. So one is just terminology, implementation process, and then implementation or integration strategies that we might use in our work. So I'll start off with the implementation process approach, right? And again, in the paper by Jennifer Lehman, they really do a nice job distinguishing between these terms because they help in our thinking and then how we're going to conduct our science. And so using that approach, the process that I've been undertaking in terms of planning, it's been a while. We've been working on this, and I think it's important, again, from a health equity place, that we recognize that it takes a long time for us to be able to mitigate a lot of the inequities that we've seen in our communities, and that it's not going to be a quick fix. So the planning, educating phase is really important. And how did I do that? I created this team, having university, me, and other research assistants and a clinical team support this idea of how do we begin to promote physical activity. We defined, right, and collaboratively and with also community leaders, that Latinos would be a target population because, again, the growth and the huge disparities we see in service and care for them. And then did everything from the development of the questionnaires and data we're going to collect that really centered equity, including the leadership at my local healthcare provider being open to asking questions about their experiences around racism, experiences that they may think are related to their immigrant status. And so we embedded that in the development of our questionnaire. And in addition, right, a Latina, I said before, I speak Spanish fluently, but also making sure that our questionnaires were translated not only linguistically, but culturally. So spent lots of time doing that, got on board a clinical team that would support this project and help. And our local healthcare system has been facing some challenges, I think, not unlike other systems. And so people may come and go, but I have the buy-in of our local leadership to continue this project. And then again, in terms of data collection, it's just developing these surveys, identifying who we will survey. So we decided patients, we're going to do staff observations, and how do we even begin to think about referral systems to promote physical activity? What does that look like? Our local healthcare provider has this real-time tool that they've adopted. And so it's a really great opportunity to be able to test how we can, before, right, as it's being rolled out, to test these pre-implementation approaches that may be necessary for them to more effectively use that tool. And if we're going to refer people to physical activity resources, what does that look like in our local community? So I've had some support with that, with students working with me to identify physical activity resources, taking us to our implementation eventually strategy, right? That integration strategy, again, that to me, this paper was really helpful in saying, okay, I'm trying to integrate these systems, and that's what my focus will be. So in the next phase, it's what will that look like? What will the acceptability, feasibility look like of integrating these systems? Next. And I'm going to move a little bit quickly here because I know I'm running out of time. But again, this is another nice framework that explicitly addresses equity in implementation science. And I think the more important point here for you to take away is that inner and outer context, right? And so we, unfortunately, in our work, often can't address those really big, broader systems that impact our communities and that have a long legacy, unfortunately, in the United States. But we can begin to think about how they may impact our work. Next. And so this is where I am right now with this project. So again, high-level leaders are important, right, for this work. There's been a lot of change in my healthcare leadership team and in my project, but there has been and continues to be an explicit commitment to this work. So I think finding champions is really crucial, right? And having that leadership buy-in to ensure continuity beyond the people that you may establish initially in your project. And in terms of those inner and outer strata that we need to work on to address equity, for us, as we're thinking about and assessing, and this project is still evolving, we have one publication hopefully out soon, just with the model, describing the model. We have transportation that's been secured because the hospital system already has that. So if we're trying to get people out to services or bring them into services, right? We have that built in. We're adapting, right? So we're having a menu of culturally relevant programs. So it's not enough for us to just understand what physical activity resources may be available, but what would our community most like? Is it a neighborhood level physical activity program, walking groups, family-based programs? And then again, that outer strata, right? Those broader systems that are really hard for us to address. is for us to begin to tackle them a bit and think about how they impact our work. And for us, it's been about recognizing that that referral system needs to have some trust built in between the clinical care systems and the community-based programs that are being asked to use the system for referrals. And so the way that system works is that people come into clinical care, they will be referred out for a lot of social determinants of health needs, and we're tacking on this physical activity promotion. But there's questions about the effectiveness of that tool. And what we're learning is that building trust in the use of that tool is important. We're also needing to ensure that the language is appropriate, right? To refer people to these physical activity programs. And then the last big one that we'll have to tackle as we move forward to implementing this project is, how will we ensure that this will continue beyond this pilot stage and beyond the funding, right? And we're hoping that physical activity, because it is one of the areas that has been identified as a social determinants of health framework for a lot of the work the hospitals are engaging in, would provide that continuity for this project. And next, that is it in a nutshell. I think I went over, apologies for that. But again, here, I just want to acknowledge collaborators and my funding resource for this project. And I welcome questions or comments. Thank you so much.
Thank you so much. And we're gonna, I think we're gonna integrate some of the questions that we've gotten for our speakers into the panel discussion coming up. I wanna invite April O from the National Institutes of Health back on to moderate that panel with all three of our speakers that you've heard from this morning.
Great, thank you so much. I really enjoyed these presentations, and thank you so much, Taryn, Gabriella, and Sandra, for sharing your expertise and your work and really illustrating some examples around application of implementation science, specifically with a health equity lens. I just want to take a minute to reflect on these really great talks. And while I'm doing that, I want to encourage folks to please put your questions into the chat. There's that Q&A function, or send the question through that the broader chat function to everyone. One of the key pieces that I heard from all three talks is that intentionality around making health equity really explicit in the work that you do. There was clearly a self-reflective process that all of you underwent as a researcher and as a person, and some of that power dynamic of being an investigator, but also working within a community that has existing structures, culture, and history. So I just wanted to acknowledge that intentionality that the three of you exhibited in the work that you've been doing with your community partners. It was really clear in developing the implementation strategies through the three examples as well, around thinking about social determinants of health. So Taryn had identified as a key example of thinking about equity is how are social determinants of health operating and impacting the context within which our communities are living, working, and playing, and how can those be integrated into our implementation strategies? And Gabriella shared some key examples of doing that with food security and thinking about context. And Sandra shared that as well, and thinking about pre-implementation. What are some of those barriers? The other piece is that the three speakers really identified that you can integrate equity into models and frameworks that are driving the research questions and your hypotheses, as well as identification of those measures. And there's ways to do that. I really liked what Gabriella had shared in terms of looking at those theories, models, and frameworks, but also working with community partners to identify what are the right equity constructs that are most relevant to them, and using that to drive and identify what are the measures that would be identified, as well as the implementation outcomes. Also really appreciated what Sandra shared around adaptations that may be locally necessary, as well as culturally relevant and important, recognizing, again, some of the unique needs of a particular community, and also listening to community voice around that. Another key piece, and this is my bias, I know some people, earlier today we had that chat and question about where you might identify yourself as either new to implementation science or an expert or continuing to learn. And I think you don't have to necessarily be an implementation scientist I think that in thinking about even intervention design, in dissemination, in the work that you do as a researcher, a practitioner, or as someone involved in policy, it's about understanding where implementation might fit. And I love that this panel was able to identify some key opportunities in thinking about pre-implementation and getting ready for scale up and getting ready for fidelity and adoption and adaptation. So thank you all for those and the chance to reflect a little bit about your presentations. So with that, I'd like to start off with one question from the audience. And this one is for all speakers. I'll start off with that. There's a question from the audience about how to measure the adaptability of interventions, very specifically in planning for implementation, measuring context or culture, and how it might impact implementation. Are there any suggestions about particular indicators or different methodological approaches that you might take? And for this question, I'll go around and I'll ask everyone, please feel free to, on the panelists, just unmute and jump in.
Be happy to. I'm going to start by speaking about that sustainment example that I shared about at the end of my talk. One of the things we're really interested in that study is places that have been able to sustain. We have quantitative evidence and are collecting qualitative that they're doing that through adaptation. And sometimes those adaptations are fidelity consistent and sometimes they're fidelity inconsistent. So one thing we're doing in our site visits is tracking those adaptations and categorizing them that way, consistent or inconsistent with fidelity, but also using the MADI framework to think about where are those adaptations happening? Is it happening to the frequency, to the content, to the delivery mechanism? And so that's a resource I can share in the chat that I would recommend for thinking about MADI. It's an expansion of something you may have heard about prior called FRAME, but it's also been expanded to think about how you can think about adaptation more proactively and also assess it reactively. So yeah, I see that people are dropping it in the chat too. So that's great.
That's great. Thanks so much, Taryn. Gabriella or Sandra, anything else to add?
Yeah, I just put in the chat. So there's a quite a, I would say it's fairly robust body of literature around adaptation. There's definitely some discourse around whether we would say adaptation is it in itself an implementation strategy to make an evidence-based intervention work for that context. So it can be viewed as that. And I know that it's not always clear cut with definite schools of thought being sort of in agreement, but I myself would say that adaptation is a really big part of the process. And I think it's one of those ongoing processes. And so that's why it might not necessarily be considered as one discrete strategy over something else that we might be able to capture a bit easier. But there's one article by some colleagues at Alabama is an amazing influencer in the field. And the FRAME is a really nice way to pragmatically document how a site, whether it be an early childcare centre, a school, a community centre, adapts an intervention to meet their needs. And it basically just helps them to sort of, I think it's also a validation tool to say, hey, we realise that if you're taking an intervention, so say, for instance, knapsack or another intervention or Taryn's model that's amazing and worked in Arkansas, let's say we want to take it to Philadelphia and adapt it there. There's obviously things that we need to consider for the context you're working with. And so I think we just sort of normalize that discourse more about, did you adapt it? Great, yes or no. How did you adapt it? And what's that going to do for you? Because ultimately, we don't necessarily have to care about fidelity as the biggest outcome. And as long as you have those key pieces that make your intervention work, it's completely okay to say, this is what works for our context. So, but I wouldn't say like you could, I suppose the question's really great, but I wouldn't say you have to worry so much about measuring if something can be adapted. You know, that's really up to the decision makers at that level and the key implementation expert to say, this is going to work here, and this is how we changed it or adapted it. So that, hopefully that helps.
That's great. Thank you. Sandra.
I think I would just, yeah, thank you, April. I think I would just add that part of that ad. So I loved what you just said, Gabriella, right? Is that I think people should really, that's the goal of adaptation, is to make it very local and culturally relevant. And part of that, for me, that cultural adaptation is working with your community to make sure that that you're capturing what that means. I think oftentimes it sounds an intuitive process, but I think we want to be reminded of that we need to include people on our teams that represent our communities, but really give them that voice so they can help us shape what that would look like, right? So for example, for promoting physical activity for children, I think someone put that in the chat. I would say that often what we see communities requesting is a kind of family-based approach, right? So you may think of it as just targeting the child, but the child comes with a parent, with a family, right? So you may need to adapt it by having adults or some other family level kind of approach to make sure that that child is engaged in physical activity. And so that to me can come from the local community that you're working on and where that might take place. Will it again be, and this is part of what I was sharing with our project, is what would be that kind of menu of options that we can give communities, right, to do this work? So is it going to be in a school-based program where you invite the parents to come support the child as they're engaging in physical activity? Or is it going to be at a local park, right? And so also going beyond kind of just one approach. I think Taryn mentioned that, Dr. Swindle mentioned that earlier, right? Being really innovative and flexible about how we do our work, and that it doesn't have to just be under one kind of rubric, right? I think that would be important. And then also we do have, right, in terms of research design, you can actually simultaneously test, right, whether your intervention, if you're modifying it significantly, whether it's effective. So you can design an implementation study where you're simultaneously testing that approach, right, that strategy, and also testing the effectiveness of that intervention.
Thank you so much. That's a great point, Sandra, about, hybrid designs or hybrid studies where you're able to test that implementation strategy and the effectiveness of the intervention. We can include that, certainly some papers on that, and it's also available on the resource guide if folks online want to learn more about those types of designs. It's really clear to me that the three of you have this common theme around community engagement. And community engagement, I'm hearing, is both an implementation strategy, but it's also a means by which to give power back to community. And as a group that has really integrated intentionally health equity in your outcomes as well as in your process, I was wondering if you might be able to just reflect a little bit and share about some of those methodologies, some of your own lessons learned about what really worked for your communities and things like related to sharing that power, sharing decision-making, how you intentionally planned on either having this as a specific implementation strategy or as part of that equity as a process effort. And if the three of you could address that, and then I'll go back to questions from the audience.
I'll jump in again just for ease of flow. We think about community engagement as baked into the process when we're trying to do equitable work. So we don't do any projects that don't have an advisory panel of community partners as well as frontline implementers and in those that are impacted at the end. So for me, that's multi-level. Parents are at the table, teachers are at the table, directors, their administrators. It's multifaceted. And so even there's power level or power dynamics there that are imbalanced. So we do have to be really intentional about that. And some of the strategies that we use are liberating structures. They have a beautiful website that you can go to. That's how we structure many of our community advisory panel sessions. We use those structures to set the stage, to ask our questions. We also do tangible activities like card sorting when it comes to prioritizing barriers and facilitators. We do voting and ranking activities to make sure everybody has an opportunity to give their input. We do round robins. We have some really, if it's virtual, for example. So we've really had to think about that. And I appreciate the question, April. It's important that we're intentional in structuring those sessions in a way that we're drawing out everybody at the table.
Thanks so much, Taryn. I think we hear the word engagement and in implementation, but I think it's really nice to share some key examples of what works so that folks can start thinking about how you plan to integrate those and as you approach communities as partners. Sandra and Gabriella, anything else to add to that? Would love to hear your advice.
I think another topic that we also want to be intentional about, right, is sharing in terms of, you're asking about how do we dismantle power imbalances, right? It's funding mechanisms too. So I've mentioned that right now I have a pilot study. And so one of the agreement we reached with both my local healthcare provider, community-based organizations, folks that are involved in this project is that it's a small study. So I couldn't fund everyone, right? But we are also giving opportunities for my local healthcare providers to have staff be a part of the research process, right? So they wanted to engage in the data collection for their own institution. So that was something that we changed. I had to submit a new IRB, right? To allow, and it also changed, it was interesting for them, right? To think about, okay, we're going to collect data here. And what does that mean for us, right? So I think it was this really interesting moment for them. And then moving forward, what we're thinking about is that for the next funding, hopefully I'll get funded for this project, right? In the future is that we bring them in as collaborators, right? To have funding. And so that I think that often imbalance is what creates that distrust and that distance with our community partners, because it often comes to our universities only, or we give our community partners a very small financial role. They'll be consultants, but yet they're the key people that we need at the table. So I think really having a conversation about this and us recognizing that privilege we bring when we come from a university setting in this work. And what that creates, right? The dynamic that creates with our community partners or other partners, and trying to mitigate that. And I think really being open to recognizing that if we want to dismantle power imbalances, that's also one area where we need to work on really hard to do that.
Great. Thank you for sharing that about power and how that impacts relationships and some transparency too in that dynamic. So thank you for that. Gabriella, anything to add?
Both Tyron and Sandra have made amazing points, and I just briefly want to just add, it doesn't take much, but we need to start paying people for the time that they give for projects. And it's been a common theme, and I mentioned this, but I'm actually just upstairs from the IS2 retreat at the moment, and we're talking a lot about equity and implementation science, a massive theme of this retreat. And so this is investigators from not just the obesity space, but other clinical settings. We just have to start actually giving money to people because this is their time. And we know that teachers and community health workers, early child education teachers are far underpaid. So we're already asking to do things that, yes, it's helping them do their jobs better, but it's like, what inequities are we creating by sort of constantly going to them with data collection requests and coming into their spaces? And that can take many forms. So for instance, in a grant that I just applied for, I've budgeted to have someone literally from our community engaged research office to pay part of their time, but for also to pay for time of teachers in the schools, just even if it's a gift card, something that's going to help them. And I've also had other mentors that have gotten larger grants. I'm still in the peasant early career phase, right? Billing for people's utilities, electric, gas of these facilities and clinics that they're entering and using that space. So this can take many forms, but I think this is a clear way of saying we value you. And I think it's not enough for us to continue to say you should do this because you want to do it. And so it sounds a little bit transactional, but we have to just be able to say that. And if we can't pay them with money, what can we do for them? What service and time can we help them with? So I didn't want to repeat what Taryn and Sandra so eloquently put, but that's just a really key thing that I think we should be really just normalizing.
Great. Thank you for that. I mean, what I'm hearing for that too is really value for time and expertise of partners that are participating in this work. So thank you for sharing that. We have a question for, to all panelists, thank you for sharing your reflections on that. Such an important piece as we are doing implementation work is really we're working and rely on our community partners to be able to do that work. So thank you for highlighting those lessons learned and some examples for approaches. So we have one question for Sandra, specifically on what are some ways to address cultural barriers in order to facilitate physical activities for kids in low resource settings? So if you don't mind reflecting a bit about that cultural barriers and some of that pre-implementation work that you had highlighted.
Yeah, thank you for that. So I can give some examples for this current project and prior work that I've done actually with Latino communities and promoting physical activity in park settings for both Latino adults and Latino youth. I think, again, some of the cultural kind of barriers is sometimes people, especially if they're immigrant, right, relatively new, see that their spaces may not be welcoming. So depending on where people are coming from, parks, for example, I'm going to use that as the one example from an earlier work that I did a few years back, sometimes don't have the resources that people expect, right? So in many parks in Latin America, there's food, there's music, there's water, and sometimes where people are living, they don't have access to many of these resources. And so what we've had to do is say, okay, so we understand that. So can communities, neighbors get together to have these programs put in place, right? To work with city planners to say, can we put a water fountain in this park? Can we hold festivals, activities that will make people more likely to come to the park and engage in the park as a resource for physical activity? So those are some of those cultural kind of adaptations, right? Cultural nuances that come from you working with community members about why they're not going, right? There may be a neighborhood park that they're just not accessing, right? And then building on that, there's also other structural factors that we need to recognize, right? It's these safety issues. And sometimes they're very real, but sometimes there's perceptions about the safety of these parks that we also need to address. Because sometimes the parks don't have the activity that people think they do because they just haven't even accessed them. So again, it's bringing in your community leaders to say, if we go out and we use it, you'll actually see that the park is actually a great resource for you to engage in. And then more locally here, what we're finding in terms of just cultural barriers is, as we know, right, in physical activity research, there is often a drop at the age when kids engage in physical activity. So again, we've been trying to think about how do we get parents and children more connected around maybe family-based approaches that can mitigate that. So often you find that adults are willing to engage in physical activity, but they see it separately for them and then for their kids. But there are social barriers, right? They don't have enough time to go take a kid to programs just for kids. So we can combine them. I think we can get at some of those cultural nuances that may be more efficient for us in building out these interventions and promotion of physical activity as a concrete example.
Yeah. Great. Thank you so much for sharing that from your work. We have another question from the audience. Sometimes it is difficult to see the line between implementation science and basic intervention planning. Could the panelists say a little bit more about how this line is defined and to what extent is it important or helpful to be clear about that distinction between implementation science and intervention planning?
So incredibly important. So the resource that's in the packet from today about where are you on the subway line, Dr. Megan Lanefall and Dr. Curran are co-authors on that publication and others, but check that out as a key resource to help you with this, because it's critically important to understand where are you in the process. And we're not doing implementation science proper until we're asking questions, research questions about implementation. If our questions are about, does this intervention work? For whom does it work? Those are still intervention questions. But if we're asking questions about, do these strategies work? What are the impacts of our implementation strategies? We're trying to generate generalizable knowledge for implementation science. We're definitely doing implementation science at the far end of the subway line. So there's many steps along the way, which I love. And so you don't have to be all the way there to be doing valuable work, but it's really important to understand where you are. And I think that resource is great for that.
Great. Thank you so much, Taryn. One more question from the audience. Is there any strategy about what implementation indicators are most important to measure, depending on the type of study? I think some of this likely has to do with your research question or your goal, but I'm wondering if all the panelists offer different theories, models, and frameworks that helped guide. But I was just wondering if anyone could reflect on any of your own strategies or approaches for identifying those indicators.
I would say it does depend. It depends on your research question, but it also depends on, just as Dr. Spencer said, what stage you're at. So if you're trying to do, we had different types of trials, right? Different types of interventions that you're trying to look at. So if it's more on the sort of type 1 end, which is really where we're talking about effectiveness and then implementation as a secondary focus, then some of these questions can relate more to things like feasibility, acceptance. But then if you're really talking about an intervention which has been ongoing for a while, you've sort of done a lot of or preliminary work about its effectiveness, but also is it kind of feasible, etc. You kind of move beyond that initial feasibility. You're scaling it up potentially. Some of the outcomes you might want to think about are sustainment, the cost of implementation. And so I loved in Taryn's slides about sort of the cost of implementation. We need to be really looking at that as a way to predict sustainment. And then also just the change in organizational readiness. So what's happening in that system to help sustain something like that. So I think it does depend on the question, but also how far along that intervention or policy or initiative is in that pipeline, in that sort of going from that effectiveness all the way up to like that scalability. And that really helps determine what kinds of outcomes you can focus on, because there are so many and it's impractical and potentially just a little bit too burdensome to focus on all of them. There's also a really great scale-up continuum that was published, and I'll try and find the article for that soon, but basically it just kind of helps you sort of see where you're at in terms of that pipeline, and how much you should focus on certain outcomes over others. So hopefully that helped a little bit in just sort of trying to break it down a bit more.
Great, thank you. Thank you all. I think Karen is here to lead us into the break. Thank you all for your great insights and sharing your experience on this panel. There are a few other questions, but I believe the questions could probably be answered in our next session, which Karen will introduce for later on this afternoon around sustainability and implementation. So I will toss it over to Karen, and thank you all for, again, for being a part of this panel and sharing your work.
Thank you all so much. We are going to take a brief intermission here and come back at 5 minutes before the hour. But while you're away, we have a question for you to think about, and you can put it in the chat now or when you come back. We would love to know what you have heard so far that you can apply right away to your own work. So please be thinking about that. In about 5 minutes, we're going to play a quick stretch break video if you'd like to participate in that. Otherwise, please get up, get something to drink, use the facilities, and join us back at 5 minutes till the hour for another fantastic session and great speakers in our final hour. All right, I think people are starting to gather again. Thank you so much for coming back to join us. And as people come back to the webinar, we would love to see your responses in the chat, thinking about what you've heard so far that you can apply to your own work. So if anyone has thoughts on that, we'd love to see them. It's very helpful to the speakers to hear what is most useful to all of you. All right, well, I think we're ready to get started again. And looking in the chat to see if anyone has put any answers in there yet. Not yet, but if you think of them as you're coming back, things that you have heard so far that are going to be immediately applicable to your work, we'd love to hear about that. All right, let me go ahead and introduce our next set of speakers. We have a fabulous panel talking about testing of implementation strategies and planning for equitable implementation and sustainability. And our three speakers today, first we have Dr. Valerie Bluebird Jernigan, and she is a Choctaw community-based participatory researcher. In 2019, she established and now directs the Center for Indigenous Health Research and Policy, which is an endowed research arm of Oklahoma State University's Center for Health Sciences. And in all of Dr. Jernigan's work, she has focused on fostering long-term, mutually beneficial relationships with Indigenous communities that promote tribal sovereignty and build community capacity to improve health. We also have with us today Dr. Courtney Parks, who is a senior research scientist at the Gretchen Swanson Center for Nutrition. And her areas of expertise include food systems and community food access, dissemination and implementation science, and collective impact and development of shared measures and community capacity. We also have with us Dr. Deanna Hulsher, and Dr. Hulsher's research interests include teaching children and their families to engage in healthier dietary and physical activity behaviors to avoid chronic diseases, with an emphasis on addressing health disparities. Her recent work has been focused on implementing interventions and evaluations on policy systems and environmental changes. She is a principal investigator of the Texas School of Physical Activity and Nutrition, also known as Texas SPAN survey, which is funded by the Texas Department of State Health Services to monitor the prevalence of obesity in school-age children in the state. And she is also PI on the STREETS project, which is an NIH-funded natural experiment to determine the effects of safe routes to school policies on child physical activities. So I'd like to turn things over to our first speaker, and that is Dr. Jernigan.
Great, thank you so much. Thank you to the organizers of the panel and all of my excellent colleagues who are presenting. And I am very excited to be here. I'll be talking with you today, as was said, about really focusing on partner engagement, intervention development, testing, and evaluation. Next slide. So we at my research center are interventionists, and we focus on implementation science. And we do so from the orientation of community-based participatory research. So we have done this for 25 years. It's really the only way we work, and it involves really intensive community partnership from the development of the research question, data collection, evaluation, all the way through dissemination and co-authoring manuscripts with our partners. That takes an incredible amount of time, and our partnerships tend to be a minimum of 8 to 10 years. So because of the way that we do this work, we have a very intentional process of developing our partnerships, and we scan potential partners very carefully. And we also, look at our own capacity to partner. And so that process, even before a grant is written or submitted, is usually about a year or two. And so when we talk about equitable engagement, I believe this is really core to that, because it's during that time that we're able to understand fit. We're able to understand what the community is interested in exploring. Do they have the capacity to conduct the research? Are they interested in testing a specific hypothesis? Are they interested in looking at implementation science and measuring how we are implementing these interventions? And so all of those questions are put forward at the very beginning of the partnership. And we also look at mutual capacity. So if their particular focus area does not involve a policy or a structural or an environmental change, which is really the focus of our work, we probably aren't a good fit as partners. And we also look at, what is the geographic distance? Do we have people in the area that are willing and able to really be on the ground with this work? And if that is not the case, then it might not be a good fit. So we take this very seriously, and it does involve a lot of conversation. And the other piece that I would emphasize, again, centering a focus on equity, is, does the community have government and policy support for this initiative? So has there been evidence that leadership is involved, leadership supports this, or will they be interested in doing so were it to be implemented? And do we have their sign off for this? If that's not there, again, it might not be a good fit for us. We are looking at long-term sustainability with Indigenous communities. There's been so much of a helicopter research approach. Sometimes things can be helped by research, but once the funding ends, the communities tend to be left without sustainable, support, and the benefits slowly go away. And so we want to avoid that at all costs. And we focus, initially on sustainability. Cultural centeredness is a big part of that. So we want to make sure that the work is grounded. It is not an external researcher's pet project or something we as external researchers are interested in. It is actually a strong priority of the community for their own health and their own, capacity goals. So that process is our partnership engagement. And if you go to the next slide, I can share with you an example of what this looks like within 2 large Native nations in Oklahoma. So this was an R01 funded by NHLBI, and it just recently ended. And this was the Thrive Healthy Retail Study. And so the tribal nations we worked with were the Chickasaw Nation and Choctaw Nation of Oklahoma. And if you look at the map of Oklahoma, you can see these 2 large Native nations comprise pretty much the southeast corner of the state. Both of them have approximately 11 to 12 counties, and they're, quite large. We took a food sovereignty approach. So again, sustainability, can we source and sell healthy foods without hurting revenue and sovereignty? What would that look like? How do we realistically get healthy foods on the shelves in very rural environments where a food truck delivery happens maybe once a week. Next slide. So the strategies we evaluated, we first did basically a two-phase development and testing process. Phase one, we looked at the existing foods within the stores. We assessed the nutritional content of those foods. And to remind you, or to familiarize those who are less familiar with native nations and convenience stores, these stores function largely as grocery stores for these tribes. So they are, quite loaded with unhealthy foods. It's a lot of fried foods, packaged foods. So given that they are grocery stores, essentially, that people shop there 3 or more times a week for food, this is why we chose to intervene in this particular location in both tribes. And so we assessed the environment, we conducted the nutritional environment measures, and then we went about developing placement, promotion, and pricing strategies. This took many months to work with multi-sector engagement processes and groups. So you have us working with tribal leadership. We worked with the convenience store managers. We worked with the Choctaw and Chickasaw Nation PR divisions, and we did a lot of testing of strategies and foods and promotional strategies with the tribal community members. And it was through this process that we settled on our sort of best implementation strategies. Next slide. And you can see we were given permission to remodel lots of the sections of the stores, to remove, if you look at the small map, before and after. Packaged food is in blue and intervention foods are in red. So the left is the before and the right is the after. We replaced packaged foods with fresh and healthy foods in walk-around coolers and in large sections of the walls in the convenience stores. We replaced end caps with healthy food options, and we placed healthy foods with tribal native language at these end caps to promote engagement and purchasing. We also priced these foods at retail market price. We tested this and realized we didn't have to reduce prices because they were selling out without reducing prices. So we kept them at suggested retail prices. So these are just some examples of the produce that we developed and the signage. Next slide. Our key takeaways: focusing on culturally centered work with a potential for long-term sustainability was really required. Engaging the diverse interest groups, as I said, takes a tremendous amount of time. It took about 2 years to plan this and to engage and to look at the different implementation strategies before we started the actual efficacy trial. And then multi-level, multidisciplinary approaches. So if we want to affect change, if we want to make a dent in the disparities that are pervasive in Indigenous communities, we really have to work multi-level. And so this project built upon existing health education strategies that were implemented in the tribal health clinics. And we worked closely with them to promote their individual level health education messages. We also planned for scale up from the beginning. Both tribes invested in the remodeling of their stores, understanding that this would be a long-term commitment and that these interventions would be sustained even after the initial implementation phase. Next slide. We always co-publish with our community research partners. Their perspectives on all stages are essential especially in implementation science, some ways that they describe things, the processes, the perspectives are essential in really understanding how to do this work on the ground. And so we very much value those perspectives at all stages, and that's reflected in their written work. We follow Indigenous research guidelines, and we really emphasize the role of community-based practitioners and knowledge holders as being centered in our partnership. Next slide. I just want to acknowledge my partners, Choctaw and Chickasaw, and the excellent support we got from NHLBI for this. And you can find a lot of the publications in American Journal of Public Health and other peer-reviewed journals. We've published on most of this. Thank you.
Thank you so much. And I think in the interest of time, and since it worked so well in our last panel, we're going to hold some of the speaker questions that we're getting and address them in the panel when we have everybody together. So I'm going to turn things over next to Dr. Parks, and then we will take questions for all of our speakers during the panel. So please keep adding those to the Q&A. Dr. Parks.
Thanks. So yes, I'm Courtney Parks, a senior research scientist with the Gretchen Swanson Center for Nutrition, and I'll be talking a little bit about implementation science within the context of program evaluation. Next slide. So first, a little bit about Gretchen Swanson. We're an independent nonprofit research institute, previously headquartered in Omaha, Nebraska, but now completely virtual with staff across the country. And we focus on food insecurity, healthy food access, and equity with an overarching emphasis in evaluation and measurement. And some of the work I'll be highlighting today aligns with our role as the NTAE for GusNIP, which is basically means we facilitate and coordinate reporting and evaluation for grantees from USDA that are implementing nutrition incentive and produce prescription projects. And the Nutrition Incentive Hub is a wider coalition of partners that provide implementation TA for these programs. And if you visit nutritionincentivehub.org, you can see more info and lots of resources. Next slide. So financial incentives, including both nutrition incentive and produce prescriptions, broadly provide incentives for low-income populations to purchase more fruits and vegetables. And on this graphic, you can see exactly where financial incentives are intended to play a role in addressing health disparities by supporting these purchases of fruits and vegetables among socially economically disadvantaged groups that participated in SNAP and also experience food insecurity. And overall, just promote healthy food consumption and lower risk for diet-related conditions. Next slide. So today, financial incentives for fruits and vegetables are supported by a history of federal policy in the U.S. Farm Bill. In 2008, the Healthy Incentive Pilot was funded to study the impact on SNAP households. And then in 2014, Congress funded the FINI program with over $100 million over 5 years. And then in 2018, the Gus Schumacher Nutrition Incentive Program was appropriated for $250 million over 5 years. And there's been supplemental funding with COVID relief and other things over that period as well. And an important point here is that financial incentives cost money and require political will, but they have bipartisan support in the US because of the documented benefits to people, communities, and economies. And I just wanted to also mention the recently held Biden-Harris administration White House Conference on Hunger. This was the second one that they held since 1969, and basically released a national strategy with actions to drive solutions and financial commitments that align with GusNIP and other programs like it. Next slide. So we've heard lots of definitions of implementation science, and I think I just wanted to highlight that it's the study of components necessary to promote authentic adoption of evidence-based interventions and thereby increasing their effectiveness. And Also wanted to highlight that evaluating programs in the real world aligns well with implementation science. So in the case of GusNIP, we're evaluating the impact of evidence-based intervention, i.e. nutrition incentive and produce prescription projects. And when considering implementation science, like to take a broader view of research that doesn't only prioritize internal validity, like much of traditional research, but balances this with external validity and how these findings can be generalized to various populations and settings. Next slide. So as the GusNIP NTAE, our main charge has been establishing and implementing shared measures across these programs. And so having shared measures across GusNIP grantees has been a leap forward for our ability to speak to the impact of these programs. We have been able to demonstrate that participation is related to increased fruit and vegetable consumption, improved food security, and millions of dollars added to local economies and economic impact across the country. And ultimately, improvements in health and healthcare and reductions in healthcare spending are what we're aiming for. And it's currently being tracked and incorporated into future reporting. But those healthcare outcomes are a little more rigorous and burdensome for both the grantees and the participants. And we're getting there. We're working towards that. Next slide. So since shared measures have to be both rigorous and feasible for all grantees to collect, there's room for addition of more rigorous methods. And so one case study or offshoot study is led by colleagues at Stanford, including Lisa Goldman-Rosas and others. And we're currently conducting qualitative interviews with a set of produce prescription grantees to determine what works best under what conditions and settings. And so this research will hopefully fill a gap in understanding, since there is such wide heterogeneity in how these programs operate, who is leading the various efforts, the types of populations and communities they serve. And this research is guided by the Consolidated Framework for Implementation Research, or CFIR, which recently came out with an update that includes more outcomes. And so next slide, I'll talk a little bit about the results. So some of the, the model. Some of the preliminary themes we are noting here include the implementation climate, which is encompassed by the inner and outer settings. For example, the impact of COVID-19 on nutrition education and food distribution, and the role of leadership and whether the lead organization is within the healthcare setting or not. In terms of the intervention characteristics, it's interesting to document how various program features have been adapted to specific settings and populations, and the role of evidence in establishing and promoting these programs. For example, what types of evidence healthcare leadership or policymakers would need to make those decisions. Next slide. So switching to another quick example of implementation science at play within GusNIP is a paper we're currently working on that describes the characteristics of nutrition incentive projects and how these factors influence the amount of the incentive that's redeemed. And so some of these findings may not be surprising, but it's important to understand during program design and policy efforts. So such as the size and type of the food retailer, the mechanism that the incentive is delivered through, and the types of supplementary activities implemented, like nutrition education, delivery, or community building activities. And so those sites that had those features tended to have higher incentive redemption. And last slide is really just in closing, and open for questions after the panel.
Thank you so much. And we are going to go to our final speaker presentation in just a moment. I want to remind you to go ahead and put your questions in the Q&A so that we can take those during the panel. And here's our final speaker, and then we'll come back for all of our speakers together with a panel in just a few minutes. Our final speaker is Dr. Helscher.
So thank you for inviting me to this panel. I've really enjoyed listening to the speakers throughout the day. And my take on this is a little bit different. I'm going to be covering a dissemination journey that began more than 3 decades ago. And it really shows how NIH trials can be used to address health equity and population impact. And so with the next slide, I'd like to first introduce y'all to CATCH. So CATCH are the Child and Adolescent Trial for Cardiovascular Health was one of the largest multi-site school-based health promotion programs funded by NHLBI to address risk factors for cardiovascular disease. CATCH was also notable because it was a large multi-racial, multi-ethnic, and low-income cohort. So we kind of addressed a lot of cultural factors at the beginning of this grant. The CATCH intervention consisted of 4 core components, and the study design was prospective cluster RCT focused on elementary school children from grades 3 to 5. So we found significant changes in diet and physical activity, as well as institutional changes in the school, but we really didn't see effects on child obesity at this point in time. And so with most NIH studies, the story ends when the main trial outcomes are published, but that's not the case with CATCH. So this slide shows an outline of important dates in the CATCH story and highlights some of our initial dissemination efforts, funding, evaluation, and legislation. So when the main trial outcome was published in JAMA, an individual at the Texas Department of State Health Services learned about the study and thought he should disseminate it across the state. So he sent out an invitation to 3,000 elementary schools to buy CATCH at a nominal price, and only 6 responded. So DSHS decided that they needed to provide a more active dissemination. And so they paid our group at the School of Public Health for training, dissemination, and evaluation. In 1997, due to concerns about childhood obesity in the area, the Paso del Norte Health Foundation in El Paso began to fund a regional initiative for CATCH. And so you'll hear more about that later. But based on statewide concern for increasing obesity rates, this El Paso CATCH implementation in the main outcomes paper, a group of community partners headed by the Texas Medical Association formed a coalition to institutionalize coordinated school health through the legislative process. So at the same time, the Texas State Board of Education approved CATCH as a diabetes prevention program for school, and the name was changed to Coordinated Approach to Child Health, because you don't want to disseminate something that has trial in the name. So in 2001, the first of many pieces of legislation was passed to provide for coordinated school health programs in elementary schools. So this was followed by legislation in 2003 and 2005, which strengthened this legislation and expanded the mandate to middle schools. So as we went along the dissemination journey, on the next slide, you can see that we had program champions as well as patron saints. So these included Texas Senator Jane Nelson, who modeled Senate Bill 19 after what she saw in the implementation of CATCH in El Paso. Her legislative aides also used data generated from our study to justify this legislation and then evaluate the implementation of coordinated school health programs across Texas. Texas Comptroller Susan Combs, while she was the Texas Department of Agriculture Commissioner in Texas, initiated standards for food served at schools. So this really helped support and leverage the coordinated school health program mandates. She also found money for the implementation of coordinated school health in middle schools. So the next slide shows some of our effectiveness trials. So as we replicated CATCH in the communities, these were replicated predominantly among low income, mostly Hispanic Latino children and families. So they included a smaller replication in 8 schools by Karen Coleman in 2005, which found a decrease in obesity among children in El Paso in schools that were implementing CATCH. So that's not part of this slide. But then we found, when we were conducting our Texas SPAN study, we found a 7% decrease in the prevalence of obesity in 4th graders in the El Paso area. And although this is mostly an ecological study, you can kind of see that it was done in an area where they were really strongly implementing through Paso del Norte Health Foundation. We later did another replication in the Travis County area, funded by the Michael and Susan Dell Foundation. In this study, we found a reduction of an 8% prevalence of overweight and obesity in children from CATCH schools compared to those in schools without CATCH. In addition, we found that schools that implemented more fully had better outcomes. So in the next slide, this just shows some of the lessons that we learned. One is that we needed scalable, culturally relevant, and evidence-based programs. So they had to fit the school context and culture, and it had to be packaged. As you can see, the relationships were important. Thirdly, we had to have data in usable format. So it really needed to have face validity as well as be easy to use. Then we also needed resources. So there were many grants that we used for this. And then finally, you have to watch for backsliding, because there were efforts to actually derail the mandates at certain times. But our advocates kind of stood up for us, which was nice. So despite our success to CATCH, we had very many limitations to growth and further dissemination. So the 3 most important limitations were funding. As you've seen with other projects here, a lot of funders won't support universities for this kind of work, just to do the dissemination work, or for-profits. Sustainability was difficult. It was difficult to get new investigators involved in this because you don't get many papers. You're doing a lot of legwork with this. We were often told not to do this work, but to write more NIH grants. And then lastly was the focus. Academics are evaluated on scientific and bibliographic metrics, so not necessarily on population impact. And we usually don't have the skills to do further scaling. So this all led to the creation of the CATCH Global Foundation in 2014, which is on the next slide. This is a 501c3 organization. And this organization was funded by a former MPH student, Duncan Van Duzen, who worked with us on this. He really had a passion. He had experience in the business world and really wanted to make a difference in children's lives. So you can't understate this passion. So the next slide kind of gives what we were able to do with this. So CATCH Global Foundation has a synergistic partner with the Michael and Susan Dell Center for Healthy Living, which I direct. So through this collaboration, our center provides scientific and evaluation expertise, and CATCH Global provides community outreach and dissemination. So our programs focus on primary prevention, and we've been able to expand those to other behaviors besides obesity prevention. We've also been able to improve our programs, quality improvement, by getting input from end users of the program, as well as ongoing review of scientific knowledge. So CATCH Global Foundation uses our work to seed social investments through community empowerment. With the CATCH Promise Initiative, CATCH Global works with schools and communities, specifically low-income populations with a public health need and district readiness, to link them to resources to implement and sustain CATCH using the whole school, whole community, whole child model. So this process of discovery, evaluation, dissemination, and sustainability is needed to achieve population impact, and in doing so, advance equity in our experience. So the final slide is just thank you to the many partners who've been involved with this work over the years, and a variety of funding sources, which include everything from NIH grants through foundation support. Thank you.
Thank you so much. And now we'd like to invite all of our panelists back, all of our afternoon speakers back, to join in a panel that will be moderated by Janet Fulton from CDC. And I want to remind everybody in the audience to please put your questions into the Q&A. We would love to answer as many of them as possible during the panel. So let me turn it over to you, Janet.
Great, thanks, Karen. Thanks, everybody. Wow, what a great session. I think, again, reflecting on what each of the speakers had to share with us, some key takeaways for me. And while you write your questions in the chat, I'll share some of the things that I learned, and I learned a ton, not only during this session, but on the previous one as well. But one of the big takeaways I'm hearing is that really work in implementation science really needs to be intentional. It needs to be intentional from a partnership perspective, from a community perspective, as well as adapting interventions for cultural issues or cultural context, thinking about sustainability, really thinking about how, like Karen was describing, making that intervention routine, whether it's through a legislative approach, as we just heard, or through financial incentives, and also how thinking about communication, putting the data that we get from the science in a usable format so that our stakeholders can really use it, and really thinking about their needs in terms of community or these key stakeholders. So this is a question for everybody, and I'd love to hear everyone's perspective. But thinking about partnerships and how vital they are to success of implementing interventions. Can you all kind of talk about maybe your approach with garnering these key partnerships, or even thinking about, in your experience, how you've managed to get private partnerships, or even thinking about navigating issues with businesses around corporate responsibility? So garnering these key partnerships.
So I can start us off. I thought Valerie had a really good point about how it takes a long time and you have to continue to nurture those relationships over time. So most of our relationships go back 10 years or more. And so I think you have to set them up in the beginning where it's mutually beneficial. So you have to be ready to provide them with the information they need. It might mean that you go and do a presentation. With us, we can travel all over. We end up traveling all over Texas, depending on what a partner needs. And it's kind of being responsive to what they need over time, because it does change over time. So, and setting up the partnerships even before you're getting into a community or whatever, but being very proactive about setting up partnerships. The worst thing is if you're writing a grant and you go and say, I want to establish this partnership right now. That's not really a partnership in my mind.
Yeah, thanks, Deanna. Valerie, you want to chime in on that one?
I'm thinking about the different groups that we engage and how we use different approaches. And so if we as researchers may have implementation questions as well as efficacy questions, when we engage community partners, that takes a very different approach than when we're engaging, for example, store owners or government leaders. And so in the example that I provided in my presentation, we really had to spend a good amount of time understanding what it was that each of those groups could get out of this. So for store owners, it was information about shopping behaviors and preferences for new and different types of foods. For community members, it was their ability to have healthier choices, to be able to meet their dietary recommendations from their physicians, for example, or to help their family eat healthier foods. For government leadership, it was interesting because it was the opportunity to demonstrate health as a priority for tribal leaders. And so recognition that the only place that health is a priority is not just the hospital, but in various community settings, we can demonstrate that we prioritize health. And this intervention may be able to allow us to show that commitment in ways we hadn't thought about before. So those were things we spent a lot of time assessing in our partnership engagement process.
Fantastic. Thank you. Courtney, anything to add, or we can move to the next one?
I was just going to add in, I think our work with GusNIP is really about engaging with grantees as kind of the audience. They're the ones that actually reach their communities. But, you know, these grantees have various levels of capacity, everything from the smallest nonprofit to, you know, larger research or healthcare institutions. And so our job has been to kind of meet them where they are and help guide them through this process of evaluation and implementing those projects. And so it's been a learning process for us, you know, even as evaluators in different settings, kind of understanding the like breadth and sort of variety of levels of capacity that we're trying to work with, and building tools around that has been kind of how we've approached it, and tools and processes, and just, you know, trying to just really support them in achieving the goals of their grant.
Yeah, so important, so important. One of the things that comes up, I think, across the board for you all is how you've managed, you know, from thinking about that end in mind and long-term sustainability, but also thinking about how you need to adapt the intervention culturally or in other ways. Could you talk about like just how you've managed to do that? And I know you didn't have much time to kind of go into the depths of your work, but talk to us a little bit about like that cultural adaptation that I think people really are interested in.
I can talk about it from the study that I shared. For example, we focused on, and we tend to do this in most of our work, we stay away from trying to reinvent the wheel. And so CDC had wonderful recommendations for addressing obesity at policy, environmental, structural levels, but was known about how to do that in diverse tribal environments where governments are different and sovereign. And so we took those recommendations to guide the implementation of this study. And we were looking, as I mentioned, both at efficacy, but also at implementation. And so we really had to look at all of the different sort of factors that play into access to healthy foods in these very rural, remote environments. And those things, I think, as Deanna mentioned, we don't typically get training on scale up, and we definitely don't get training in some of these multi-level interventions that we implement. And so oftentimes it's a very quick learning process of, how do we implement this in these settings where, you're not trained in public health research to do this. So we had to learn very quickly about the healthy retail and store environments. And I also would say we had to do a lot of assessment around what types of foods community members would be willing to try, not just taste tests, but also how much should they cost for you to be willing to purchase this? How much would they need to cost in order for you to be willing to purchase them instead of the French fries or instead of X, Y, or Z? And so a lot of that was done with clicker polls and, rating strategies. And that helped us narrow in on not just what they would be willing to eat, but how much they would be willing to pay and what would motivate them to choose those options over other options. We did a lot of that work. We also did work around the inclusion of language and how language can draw attention in those environments and emphasize. I think someone mentioned in the earlier panel about how people don't necessarily feel welcome at certain spaces. We wanted people to understand that this space was a space where it had cultural inclusion in it, and you could actually recognize the tribal language, and you could see that there was an initiative to promote these healthier choices that were indeed native. And that's part of one of the cultural ways you could implement this within an environmental level.
Yeah, that's fantastic. Courtney, Deanna, thoughts?
I was going to mention something about cultural adaptation for measurement. And one thing we've seen is when we're trying to assess diet, the measure we landed on was the dietary screener questionnaire. And there's 10 items that ask about fruits and vegetables. And, the issue of cultural appropriateness or culturally relevant foods being included or tailored to that for different populations is kind of a big issue, and not one that we have a good answer for yet, because this is a tool that has been validated and, has an algorithm behind it that's based on sex and age. And so even within sex, when you ask people their gender or sex, and there's non-binary and other identities that aren't captured, that we aren't able to apply then the algorithm to. And then even just the examples of the foods. So like when we're asking about leafy greens, like what the examples are, and needing further validation basically for culturally relevant tools to assess diet has kind of come up as a challenge.
Yeah, very important, that whole measurement area from a relevancy standpoint. Yeah, Deanna?
So I think this brings up one area that's very important for implementation research, and that's determining what are the core aspects of a program. So how much flexibility do you really have? What are the things that if you change, it's really going to change the program so that you don't get the same effectiveness? So one of the things we do, because it's school-based, you have cultural relevance, but you also have to fit into the school structure. So that's set, but you have low-income and high-income schools. So schools can vary a lot as well. So one of the ways that really has proven useful to us is training. And we know that schools that are trained are more likely to implement it over time. So a lot of our research and others have shown that. And during the training process, one of the things we do is we sit together with the CATCH team at the school, and we talk about how to implement it so that they leave with a plan, and you can individualize it at that point. So, if there are issues in terms of cultural relevance, they're usually brought up at that time. One example is in the curriculum, and this was several years back, but it's Hearty Heart and Friends. So they changed it to the Mighty Amigos. That was more appropriate for the El Paso schools, but incorporating foods that are common to the school. So kind of following up what Courtney said, food is very important in a cultural context. Those are important. And then sometimes what we've done too is look at drawing culturally relevant physical activities too. So it might include dance, it can include other forms. So those training sessions and planning sessions are a good opportunity to kind of individualize it at the school level.
Yeah. Yeah, great, thanks. And then if you think about thinking about that concept of individualizing or making information palatable to certain audiences, we're kind of research people, right? We're interested in data, publications, things like that. But how have you all been or thought about, been successful in packaging your research findings for the community, for policymakers? I'm thinking about how you communicate these key issues to them to kind of get that buy-in. It's kind of full circle with the engaging partners, thinking about translating that data so that they can really see themselves in it.
We've been doing a lot of one-pagers for the state legislature through another project that I'm involved in. Mm-hmm. And so a couple of things that we've done is, one is put the takeaways right at the beginning of the one-pager, bullet them, try and avoid lots of text. We also try and present the data in colorful graphs, or we use icons to look at it. Sometimes the language can be a problem. So when you're communicating with certain stakeholders, some language is a turnoff from the very beginning. So you need to know what those red flags are and figure out another way. So in some of the work that we do, for example, social determinants of health doesn't play well in some of the communities that we're in. So we'll say foundations of health. So there are other ways that you can communicate that and kind of learning those. And then it requires a lot of untraining of our academic ways, because we're used to being very precise and using words that mean, and so you have to get a little bit away from that. So it's really nice to have an advisory committee. We have an advisory committee that we vet things through, and so that's very helpful as well.
Great. Valerie, Courtney?
I'm smiling because I had to unlearn that these folks in government don't want the scientific information. And so I think that what we do the same, as was mentioned, really one page. We also specify the findings, we specify the cost. So, this is how much this intervention costs. And then we also do economic analyses, cost benefit, and projections. So we can tell the leadership, the government, if you implement these strategies, you will have the following cost savings in healthcare utilization. You'll have the following potential reductions in emergency room visits. And this is what those models that we implement, we work with a health economist, can tell us about, over time, how much money you'll save with these prevention investments. And I find that that is key to include in policy documents, is really what will this save us over time. And we started doing those with all of our our work because we really have to be doing that in public health. We have to be able to plan for sustainability with actual numbers and economic data.
Yeah, you're here. Courtney.
Well, we're still learning how to communicate to policymakers, having just completed our 3rd congressional report. It's still always like a mystery what information they're really looking for. But I agree with what Deanna and Valerie both said about, the one-pagers and trying to synthesize and get your messaging and language right. And I think with something like GusNIP and nutrition incentives, the reason it does have bipartisan support is because you can focus on these different outcomes like the economic impact or the dietary and health improvements, and then just creating buy-in with those various stakeholders through that messaging. And I think another piece of this is how to communicate to wider audiences that maybe aren't research or aren't policy, but how to make the results meaningful. And I think we're starting to explore new ways to do that through more storytelling or videos or images, less of what we're used to in research, basically unlearning, like Valerie said.
Yeah, unlearning. It's so true, isn't it? I'm going to come totally full circle from the polling question at the beginning of the workshop. We see that half of us are really new to this, and so I'd love to kind of end the conversation here since we have just a few minutes left, but really to get your advice on resources. I know we've shared a ton of resources in the chat already, but other resources or experiences or trainings or ways that you all have learned about implementation science and your amazing experience, and kind of leave that with the audience in ways that they can really learn more about this area, and maybe your life lessons and what you've learned, what you want to share.
I guess I was reflecting on one of the earlier questions about measures, and I was, searching around trying to find some resources because I'm not used to quantitative measures for this space. So I guess I would say when in doubt, qualitative can help. Qualitative research can help provide that context. And when we're talking about implementation, a lot of that is just so nuanced that it really takes that level of detail.
Yeah, so important, right? Not just quantitative. Yeah, good point, Courtney. Thank you.
I would say that I got exposed in pretty early on, early 2000s, by attending a training that was sponsored by NIH. And it was on implementation science, and it was like a week long, and it was incredible. And I was really surprised that more people weren't aware of this, because I find that implementation science is a perfect partner with CBPR. So I got involved in learning through that. And then I really appreciate the journal. So I, do find a lot of interesting work being published in the Implementation Science Journal. And there's several journals now. And, really keeping up on the latest model developments too, I think, because it's a relatively new field. Yeah. The models are still being developed. And so that's what I would recommend.
Great, thank you. Deanna?
Yeah, I think I kind of agree that there's a lot more training and resources now than when we started. When we started, we were using diffusion theory. So, it was way different than it is now. So there's so many resources. But I would also say that look outside of academia. So groups have been doing implementation and dissemination research for years, and especially the business community and economic community. So I think that that's really a great place to get an outside view. And it gives you a different perspective on all of this that kind of transcends some of our more efficacy type trial framework.
Yeah, good point, right? Looking to other areas. April just put the link to the NIH training in the chat for folks who are interested in that. So thank you. And I just want to really just say thank you all. Thank you for a wonderful session. Thank you for imparting your knowledge and your wisdom, and for being, I mean, not only your presentations were great, but the way that you answered the questions were amazing too. And so just really wanted to say a sincere thank you. And I will now pass it back to Karen to close us out. So thanks.
All right, thank you all so much. We have 2 requests for all of you in the audience. So before you leave, please listen. And if you're able to help us out, we'd really appreciate it. The first thing is that we would love for you to tell us in the chat whether there was something that really excited you today. What excited you the most that you heard about? What is something that you will take home and use immediately? What are your biggest takeaways? What was most surprising to you? So that's our first request, is to let us know the answers to some of those things in the chat right now before you go. And as our next step after this workshop, NCCOR is going to continue to think about what resources and materials are needed to advance implementation science in the childhood obesity field. And so we hope that you'll let us know after the workshop today how we did, and let us know what more you think is needed. More webinars, more guidance materials, tools, toolkits, learning modules, in-person think tank meetings, whatever you can let us know about. Please take a moment right now. We're going to open up a survey as the workshop ends today, and you can answer some of those questions about resources right now. And if you don't have an opportunity, we'll share the link to the survey out again in just a couple of days, so you'll have a chance to respond to it then. But again, if you can let us know a little bit in the chat about your immediate takeaways and how you will use today's information, and then let us know in the survey about resources that you would like to see developed for the future. That would be wonderful. So thank you again to all of our moderators, presenters, and to all of you attendees for joining us today. It was a fantastic workshop, and we hope to see you again soon. Take care and have a good rest of your day.